The aim of these pilots has been to develop non-medical healthcare professionals in both operative and peri-operative care. There have been numerous titles in existence, but following public consultation, the title Surgical Care Practitioner is being adopted by those who provide care for the patients before, during and after their surgery, and who also perform some routine operations after appropriate training. In addition, the perioperative specialist practitioner is a new role looking after patients before and after their operations in the surgical ward setting. Both roles are part of the surgical team.
The Changing Workforce programme really set out to try and support organisations in how they explore new ways of working. And we'd really encourage people to be, very innovative in their thinking about how they might do things differently.
I'm never going to be a doctor. I'm not aspiring to be a doctor, but I want to do and provide a good service for my patients. That's the exciting bit for me. I'm going to make it better for the patients that come through this department, make it easier for them, less stressful, more friendly for them. I'll be able to give them more information, spend more time with them. Usually it's very rushed for an SHO to do this because as soon as he's finished, he has to dash off down to main theatres or go and do ward work. That won't be a problem for me. They'll be seen by me before theatre, during theatre and afterwards as well.
You're still at 45 Stuart Road?
Yep.
That's right.
The difference the PSP training has made to me is really breaking down professional boundaries that I had before, or allowing me to work to what I'm capable of. I mean, it's given me the training to work at a perhaps higher and broader level than I previously was able to. And I think this is the whole thing about the PSP training, that we're no longer constrained within our previous professions as a nurse or ODP, or in my case physio, that we can actually do so much more outside of that. On the whole, I'm on the wards, so if somebody needs a blood test urgently, or if they need an ECG reviewing, or if they need a chest x-ray reviewing, I can review it. We don't need to wait around for somebody to be coming out of clinic, or once they've finished the ward round or whatever, that it can happen straight away. The result for the patient is they get better quicker. And improving patient care is what I'm here to do.
That's fine.
Great.
Particularly in a treatment centre environment, what I'd like to see is we're already dealing with a cohort of well-prepared, selected patients, or basically well patients with a particular surgical problem. Now, to my mind, a well-trained PSP, perioperative specialist practitioner, could go and see those patients and make the first sort of assessment, and actually I could go be set up in theatre, and then the patients come in, I say hello, I've got good credible information which I trust from a fellow healthcare practitioner, and then the long and short is I could do 8 cases in a list rather than 6 cases, and I think that would be an improvement in capacity. People wait less long, but they're still getting a good service. I think it doesn't matter who gives the care as long as it's of an undeniable high standard. People want to be treated well, they want to be treated competently, quickly, and to be treated in a humane way. And you don't need to be a doctor to do that.
Clearly for me as a clinical manager, it's made a huge improvement in patient care. The surgical practitioners have actually improved access for patients. We've reduced the number of cancellations. We've improved the throughput of our lists. We know that we can probably get one more hernia or one more varicose vein actually done on our list. And for me as a manager, with specific pressures around waiting times, that is a huge benefit, and a huge benefit for the Trust.
The role of the Royal College of Surgeons of England has been established for hundreds of years, in that it has been the custodian of standards and it has been the maintainer of standards. The standards for surgery must be the same, the values are the same, whether the professional is a nurse, a non-qualified medical practitioner, a perioperative practitioner, And we are working extremely hard to develop a curriculum for nurse practitioners, for those who are interested in developing skills within surgery, not necessarily the ability to do major operations, more the ability to look after surgical patients, in other words, to care for surgical patients. And we are working with the Modernisation Agency to ensure that that happens in the shortest possible time.
Strategically and nationally, the partnerships have been absolutely invaluable. We've also got the collaboration with the College of Surgeons of England, which is an important development because surgical practitioners training is equally important, but when you are in a training hospital and you've got junior doctors, their training is absolutely imperative, and we've got to work in collaboration with them. We've got to work in collaboration with that team, and therefore working alongside the college will ensure that what we do develop, what the framework that we try to introduce, will take all the priorities into consideration.
There are two different key personnel really. There is the clinical supervisor, the surgeon, but also there is a mentor within the actual employed area. That helps them to ensure they do get the opportunities that arise. Our role within this area is to enable the practitioner to discuss their own local needs and look at them within the context of the more global points that they need to learn and look at how these might be applied. I do have students who have done my course from as far north as Scarborough and even as far southwest as Plymouth. Clearly that's a very long distance from Greenwich, and I do provide opportunities for the mentors to join me and the students in the classroom for a couple of sessions. But if that's not possible, then there is always the opportunity for discussion via email and via telephone.
Most doctors and nurses are hard-pressed to try and deliver the services, and we have to look at innovations and new ideas as to the way we can deliver these services. And I believe that the use of nurse practitioners is this way. You need someone who's going to drive it. You've got to be able to convince your colleagues and management. Once you've got that someone with enthusiasm and you can show them how it's working, there's no doubt that it works and people buy into success. Their contribution is going to be invaluable. My nurse practitioners in colorectal surgery have seen over 1,000 patients that otherwise would have had to be seen by a doctor in a clinic. They're able to prepare the patients, they're able to put reports in for laparoscopic procedures, while we will still be doing the ward rounds, so the actual theatres can start on time as opposed to 20 or 30 minutes late.
I think the really positive things that are coming out are the team working. The people who move into the role feel as though they've just got such a great opportunity to expand their practice. Junior doctors, I feel, are being freed up to get the training and the experience that they really ought to have in surgery. And certainly the consultant surgeons are finding that this is somebody who's a permanent member of the team. They really value those people in the team. And I think they also give that continuity of care for patients. And the one thing patients say to us is they would like to see fewer people. And a familiar face is really, really important to people. And I think we're going to see this as something that's the norm and not something that's new.